we have Ms. Sheila Thorne, and Sheila Thorne is the president and CEO of the Multicultural Healthcare Marketing Group. And Sheila is here to speak with you tonight again about exploring diversity in the multiple sclerosis community. She'll be speaking about the topics that you see in front of you. This program is supported by Genentech. And again, this is just being provided to you by MS Views and News. So Sheila's going to speak for about 30 minutes, and then I'm going to come back online and I'll take whatever questions that you might have. So let's take it away, Sheila. I'll give the ball to you and you're up and running.
Thank you so much, Stuart, and welcome everyone who've agreed to join us tonight to talk about a topic that clearly is relevant to what we're experiencing in our country. Kudos to MS Views and News for keeping diversity on the forefront with respect to anyone living with multiple sclerosis. It clearly is an opportunity for all of us to learn more. Before we move forward to the slides, I want to take a look at the title of this presentation because that always gives me a sense of what those who organize this meeting want to hear. First and foremost, the word exploring. To explore something is to analyze it, to study it, to investigate it, in the hopes of becoming more familiar with something. So we're going to explore diversity. That word diversity also has multiple meanings. Diversity can mean age, it can mean income, education, it can mean gender, it can mean literacy. It has a plethora of meanings under that. But tonight we're going to talk about race and ethnicity, and that's going to be specific. And certainly those of you who are living with multiple sclerosis, who have loved ones or friends, or who are studying, who are in pharmaceutical companies that are studying it, this is something that is top of mind. It is a chronic disease, a long-lasting disease of the central nervous system, an autoimmune condition. And because it is more prevalent in African Americans and Hispanics, it's more regressive in African Americans and Hispanics, and there are more frequent relapses in this population. That's why MS Views and News sees how important it is to include this topic in our conversation. So that's my task for today, to help you to understand what I've learned on my journey about diversity, race, ethnicity, and health. Next slide. I think it's going to be critically important that of all the different parts of diversity, this presentation is about race. And I always think about this statement because it has remained true since it was first stated back in the late 90s. Race is a significant factor in determining whether an individual receives care, whether an individual receives high quality care, in determining health outcomes, and then also where you get care, because your zip code is more important in this case than your genetic code. So advocacy comes to play. If race is the most significant factor, what about race? Does it matter? How does it fit into a person that may have multiple sclerosis or living with it? So you either become your own advocate, or if you're a friend or a loved one or a caregiver, you are an advocate for the patients. It comes with the territory. Next. But there's clearly an opportunity in this particular area because we don't know enough about multiple sclerosis in people of color. Why? Well, because many of these populations are reluctant and resistant to volunteer for clinical trials. And these trials that are put on by the industry do not represent the US population. Just look at this slide. The research that's done by NIH, 63% are white, 63.9%, only 36% are of color. The next, if you look at industry-funded trials, 83% are white and 16% are people of color. And by the way, in my business, we don't use the term minorities because it's marginalizing. We use the expression of people of color. But we clearly have to do a better job, because if we're going to explore how diversity and race impacts this disease, we've got to study it. We have to know more about it. Next. But the FDA has stepped up to the plate. Up until the year 2018, clearly it was only encouraged to have a proportionate number of people of color in clinical research. It was strongly encouraged. It certainly was something that was important to scientists because it's not about race. It's just about good science. And so this really did not give those who were involved in trials anything more stronger than just being encouraged. But things changed. Next slide. In 2022, it became law. You are now required to have a proportionate number of people of color in clinical trials in order to get the drug, the device, or the intervention approved. Long overdue. It is now the law. And the FDA has stepped up to the plate to make sure that any of those who are involved in clinical research understand this important dynamic. It's not new. This was strongly encouraged back in 1997, but it's taken almost 40 years for the industry to catch up with what science demands. Next slide. What are the challenges? Why don't we have more people of color in clinical research, especially with regard to multiple sclerosis, so that we know more about how folks get the disease, treat the disease, and live with it? Well, here are the reasons. There really is not enough information in these communities about multiple sclerosis. And then whatever information there is there, it's often not correct. So there's misinformation there. But probably the key factor in why those of color don't volunteer is mistrust and distrust. They do not trust the system. They do not trust health providers. And if you really want to know how deep this goes, I suggest you read this book called Medical Apartheid by Harriet Washington, which traces the dark history of medical experimentation on Black Americans from colonial times to the present. I'm sure you all know about the Tuskegee syphilis experiment. That's just a metaphor. It happened long before that, and it's known in the community. And then part of our conversation this evening is going to be about social determinants. What are social determinants? We'll talk about that in a bit. Another factor that has come to light, many physicians don't ask their patients if they would be interested in being part of a clinical trial. They're simply not asked. They're not hard to reach, they're hardly reached. That's a problem. So we have to also educate our physician population in terms of making sure that if they have patients who may be eligible, that they're aware of clinical research. And then sadly, there's systemic cultural deficit. That's why we're doing this tonight. Many of those involved in clinical research or in treatment don't understand culture, don't understand how race fits into those living with this disease. So this is not easy, but it's doable. And I've had the privilege of working on 17 clinical trials where increasing diversity was the goal. I'm currently working on 2. So I am happy, I am ecstatic that it has now become a condition of the agenda for anybody in clinical research. So think about these things, about what you may be doing, and see whether or not you can help mitigate some of these challenges in increasing diversity. Next slide. Well, again, this term diversity and the race and ethnicity and health issues are not new. It started back in 1985 from a historical perspective, which was one of the things that I wanted to share with you, with the Heckler Report. It was actually called the Malone Heckler Report. Thomas Malone was a biostatistician for NIH, and Margaret Heckler was the head of the old Health Education and Welfare Division of the federal government. Well, they set out to study whether people of this country got equal care. And what happened was this 9 volume of 3,000 pages was landmark. It clearly denoted that people of color, Black and other so-called minorities, do not receive quality care. So in America, we went from exclusive to a more inclusive. Next slide. Then between 1985 and now the current year, the Agency for Healthcare Research and Quality issues disparities reports on a regular basis. So we can keep track of how much progress we're making or not making with regards to eliminating racial and ethnic disparities. And that clearly is a goal, especially if we want to strive for health equity. You cannot have health equity unless you eliminate racial and ethnic disparities. So we're working on that. We've done better in some areas than in others. And multiple sclerosis is one of those areas where we need to do a lot more. Next slide. Well, here is the major landmark study that puts us into the mode of understanding and appreciating the diversity and the disparities. This book, Unequal Treatment, a landmark study, 1999, Congress requested the Institute of Medicine, a part of the National Academy of Sciences, to study, do people of color really receive inferior care? And this was a public meeting where they discussed many of these findings, and there were heated debates. I had the privilege of attending some of those meetings. But if you look at the title, Unequal Treatment, that phrase is used in the civil rights legislation. So it's not just the right thing to do, it's a civil right for everyone in America to receive quality care. And you might look at the subtitle, Confronting Racial and Ethnic Disparities in Healthcare. You can't wait to fix this problem. You've got to jump into it. But the major finding here was the same as was found in 1985, that health disparities remained after adjusting for insurance, income, education, and the system itself. Racial and ethnic minorities receive less than quality care in America. Disturbing, sad. We're making some progress, but we've got a long way to go. Next slide. Clearly, health insurance and income are two of the things that people often point to as to why people get sick, may suffer more, and die prematurely. And there's no question that those two things are critically important: no health insurance and poverty. But look at all the other things that are going on that exacerbate the existing disparities of insurance and income. Limited access to care, environmental conditions, bad neighborhoods, stress, poor education, lack of nutrition, racism. Obviously, there's more to this disparity story than meets the eye. Next slide. And here's where we come into the realm of social determinants. Well, what are they? Well, there are categories for social determinants, and this chart tells you how each one can affect a person living with multiple sclerosis. The first column, economic stability. If you don't have employment and if you don't have income, it's going to be very hard for you to really understand what the costs involved in living with multiple sclerosis. So that's key. That's one of those determinants as to how a person is going to get care and also take and pay for care. Next, neighborhood and physical environment. We know that mobility is a problem for many with multiple sclerosis. So if you don't have safe parks or a safe neighborhood or walkable areas, that may present a challenge to someone living with multiple sclerosis, particularly of color, when neighborhoods are often considered, as you call it, ghettos, if you will, and may not be safe. The next is education. Are you literate? Can you read? Can you write? And what is your health literacy? And also whatever higher education you must have also fits into the program. Unfortunately, although many of color are advancing to higher education by leaps and bounds, there are still many who don't have access to good education compared to the mainstream population. And then clearly food, diet has a factor. People in ethnic populations eat different food, very spicy food. Some are more meat food, some are more vegetables and fruit. It depends on where you come from. So clearly food is a factor of a person living with multiple sclerosis, and there also may be a factor that affects the clinical research as well. Obviously, communication, a community of social context, that's so important. Having a network of support, family, biological and non-biological, is extremely critical to a person living with a chronic disease. Having that support network. And unfortunately, many in ethnic communities, although there may be more generations in the same household, their networks may not be as useful to a person living with multiple sclerosis who may need a lot more care, physical care and physical help. So that's clearly one of the social determinants that will determine how you live with the disease. Then healthcare system. Well, that's a biggie. Is the system ready for you if you are a person of color? Or are they dismissive? Do they take your serious condition as seriously as they do with others in populations? Unfortunately, data show in recent years that racism and discrimination, unconscious bias are all part of the healthcare system, even though physicians are basically humanitarians. They got into medicine to help people. So unconscious bias may fall into play because they don't understand race, ethnicity, and culture. So these are the factors that we call social determinants, better predictors of outcomes than whether you have money or whether you have insurance. And I want to direct your attention to the gray line in this chart, racism and discrimination. That's only been added. When this chart first was released by the Kaiser Family Foundation, that wasn't there. It was added because definitely race-based traumatic stress and discrimination on a daily basis that's experienced by people of color does have an impact on their condition. Stress, as you know, can exacerbate the condition. And if you're living with stress because you're a person of color, living in a situation where you don't have the right job, you don't have the right neighborhood, you don't have a good network, all of that impacts how you live with the disease. Next slide. And the barriers to clinical trial participation are not easy to overcome. If you look at the top of the slide, those are the barriers for people of color: transportation, opportunity, caregivers, work, health literacy, research literacy, language, structural, institutional, interpersonal racism, and of course, workforce diversity. There may not be a physician of color who is there to treat you. That may make a difference to you. And if that physician who is not of color doesn't understand your culture, that can perhaps affect their understanding of how to treat you. But in the green on the bottom of the slide, here are some solutions that I've had a part in and many others, and have had success in having people of color in clinical research. Transportation vouchers, giving you the opportunity to get a coupon to take a taxi, an Uber, a Lyft, or some other transportation that's in the community. Then extending clinic hours. I've worked in clinics that are very easy to make flexible hours, perhaps one Saturday a month instead of just Monday to Friday when it's difficult for people to take off from work. So extending those hours helps to overcome that burden. The next is education. Clearly, MSU the News, who's been in the forefront of educating patients. Information is always coming out. Sometimes Stuart will send me articles, I'll send him articles, and other colleagues that work with him. Constantly learning about your disease and you. Research ambassadors, if you know someone who is living with multiple sclerosis, partnering with them, talking about it. What challenges have they overcome? What can they share with you? Creating that ambassadorship within the community itself. Investing in communities, making sure that the pharmaceutical companies who might be doing clinical research are also giving back, helping those in the community to be able to live with this chronic disease. Training for providers. Cultural competency training is now a condition of relicensure in several states in this country, making sure that providers appreciate, understand, and celebrate culture. And then the research trial itself. How many principal investigators are of color? How many of the clinical research coordinators are of color? How many of the nurses are of color? When I go to that site, if I'm in a clinical trial, do I see people who look like me? Well, there's a strong effort to hire more racially, ethnically diverse staff. So you see, the problems are not easy. They're certainly daunting in many ways, but they're doable. Next slide. And so now the FDA not only mandates you must have numbers of people of color in clinical research, but they're asking for a plan. You can't just say, yes, we're going to do it. They want to know how. And that clearly is going to give them the comfort level that they're serious about making sure that there are enough people of color for subgroup analysis to show whether this drug or this intervention really works. Some are even expanding the size of the trials, then extending the time to recruit people of color, because it may take a little bit longer, and then educating the community. Complete transparency. Tell me exactly what I'm going to experience in this trial so there are no surprises. These communities live with a very intense way of life, and so they want to be prepared. And lastly, and in my opinion, the most important part is building relationships with community leaders, with community influencers, with community gatekeepers, so that you walk in with someone from the community, which heightens the credibility and makes it more genuine, more authentic, and it lessens mistrust, distrust. So if you include these components in your clinical research, you know how diversity impacts clinical research. Again, this is something that must be intentional. It must be authentic. It must be a part of the fabric of how you do clinical research. If you know that those challenges exist, here are ways to overcome them. Next slide. And so you begin with cultural education. And I had the privilege of doing that with MS Views and News 2-3 years ago. We took each ethnic group and we went through great detail about each group, why African Americans are hesitant, what is the same, is it the same with Hispanic Latinos? What about the Asian community? And clearly we've done not nearly enough in the Native community. And we began to call that cultural competence, not cultural sensitivity. That just means you know there's a difference. That's passive. Cultural competence means you know there's a difference and you respond appropriately. You make changes, not only in your pictures and your images on your material, but in how you actually approach these communities. What is your outreach like? What is the engagement like? Do you have a conversation one-on-one, eyeball to eyeball with people in the community so that they build that trust? You acknowledge the difference. You may not always understand the difference, but you acknowledge that it exists. But first and foremost, you want to know how your own culture impacts that interpersonal relationship. That's going to be key. You may be of a different religion, a different race, different gender. You need to understand how that particular presence will impact that person of color if you're engaged with them. And then getting knowledge, reading. I'm constantly reading information about different ethnic groups. And fortunately, we can do that very easily now with the internet, making sure your resources are credible and believable and informed and up to date. And there are many that can give you that information on these groups without stereotyping, because that often is a tendency. And then lastly, whenever you're dealing with someone living with multiple sclerosis, look at their behavior within the cultural context. Not your world, their world. Having empathy for that individual because their condition is overlaid with their culture, race, or ethnicity. Next click, please, Bill. The most important factor, in my opinion, is cultural humility. Always willing to learn, always willing to know that your culture is not necessarily the right culture or the best culture. It is just different. So if you have cultural humility, cultural empathy, it won't be long until you have cultural competence, cultural proficiency, and awareness of the things that you need to know. And even though we're all well-traveled, we're all highly educated, we definitely consider ourselves smart, but most of the time when I have the opportunity to do a cultural education program with a group, it comes out that you don't know what you don't know. So we don't make assumptions, we don't generalize, but we show key factors about each of these cultures and what the common threads are. But one thing I know for sure, everybody wants to live as quality of life as possible. Everybody who's living with this condition wants to be as productive as possible. So clearly we're all on the same page with that. We are in the human family, even though there may be differences in our race or ethnicity. So once you know the population you want to engage with, learn about them. Talk to members of that race, because clearly you'll learn from that interaction. And the subgroups, the elderly, the millennials, the children, the seniors, all have different levels of cultural impact, whether they're recent immigrants or they've been here a long time. All of those factors really drive the social determinants and help a person to understand not only what one does, but why they do it the way they do. Next slide. So once you get that information, once you know your target population, once you have a target geography, where you want to go, what state, what city, what neighborhood, what zip code, then you create a strategic approach that embraces as many touch points in the community as possible so that you can help that community know that there is information about multiple sclerosis that they need to know. So you might have flyers you want to distribute in the community. You might want to go to a barbershop where Black men congregate on a regular basis and not only get their hair cut, but also talk about the neighborhood and things of interest. Beauty salons where Black women spend a lot of time. Those are the community venues where you'll find the folks that are on the ground. If you meet them where they're at, they'll respond. Of course, in the Hispanic Latino community, there are sports, and same thing in the Black community. It may be soccer, it may be baseball, botanicas, or the places where Hispanic Latinos might go to get herbs and to get salves and ointments or things of that nature. And the people in those stores I often talk to help them understand about multiple sclerosis. And some have even let me leave information there so that when others come in and want to use that method first for treatment, they have other information that they can consider. Nail salons, and of course the church. So this is the way that I get to the community to help them understand how important it is to understand their disease. I want to see it on TV. I want to hear it on the radio, read it in my Black or Hispanic newspaper. I'd like to see a pamphlet in church, in the beauty salons, in the laundromats, in the check cashing stores, in the barber shops. I want to see whether the community leaders know about this and take their advice about where to go. And then community-based organizations, chapters of organizations that have people with multiple sclerosis who come together on a regular basis. So it's a very high tech, using social media, Instagram, Facebook, all of those ways to reach every level of the family of anyone who might be living with multiple sclerosis. So that's surround sound. You use that for this approach in the way I've done it in the 27 years I've been in this space, it works. I've put boots on the ground. I've been on the ground. I talk to community, and you would be amazed at how thirsty they are for correct information that's culturally relevant. Next slide. So that's all I'm going to say about exploring diversity in the multiple sclerosis community. Exploring to study, to find new information, to learn new information, diversity, race and ethnicity as a significant factor, and of course the challenges living with this debilitating chronic condition. And community means wherever you are, in your family, in your neighborhood, in your workplace, those are where the community is. And to the extent that we're successful in doing that, we'll live better, more productive lives, especially those who may be living with multiple sclerosis. That's all I have to say, Stuart, for the time being. I'd love to hear from your audience, and you and I can have a conversation as well.
Thank you so very much. There's a lot to be learned from this. I have a question that is from me to you, all right? And that is, what's being done specifically in the various communities, like in the Latinx community, in the Black community, in the Asian or in the Asian communities? What is being done by healthcare to make the changes that are needed that have not been seen?
That's a great question, and it varies by community, Stuart. There are some communities I've worked in that are very progressive in anticipating the challenges that people living with multiple sclerosis will have. They offer transportation. They offer opportunities for resources in the community. They don't ask. They don't wait to be asked. They give them that when they have a package of information or give them on a regular basis. So if there is a medical facility, a research facility, an urgent care clinic, or any other facility, the individuals will take it upon themselves to make sure that they anticipate those problems and will give information to those who come in and make it known by pamphlets, by brochures, by posters. Again, it varies by community, but it's happening more and more, I'm happy to say.
What I'd like to know is if they're getting to the, in this case, the multiple sclerosis centers offices. Okay, are they able to have a counselor in those locations possibly to be able to speak with people who are of the communities that need more information on whether it be clinical trials or on what other resources are available for them?
No, that doesn't happen as much as I would like it, that you and I would like it to happen. It usually is driven by a personality from the community itself that really drives that effort. But I think it's happening more and more, especially if there's someone in your family that has multiple sclerosis or a loved one or a workmate, etc. So again, it's getting there, not quite there yet, and connecting with the established resources that you described for multiple sclerosis. I wish it would happen more.
I wish it would happen more as well. And How is it that the government then is able to do more for the different classifications or the different communities of people? How are they getting that information to them?
Yeah, I had a conversation recently. You made me think about a discussion I had with somebody at HHS, and they have stakeholders that they refer to in the community frequently, and they consider stakeholders a faith leader, a physician, a nurse, nurse practitioner, and they often give them the information because they more often are of color, and they'll feel that they're going to disseminate it. But again, what I do, Stuart, is community mapping. I try to find those people and give them their information, a pastor, a imam, anyone that's in the faith community, because that's always prominent. But clearly, there's no strategic plan to do that. It's all by happenstance, and it's driven by a personality of someone who just feels very strongly about it. They don't have stewards in every community, unfortunately.
There's not enough Sheilas out there then.
We got to clone ourselves, Stuart. Huh?
That's right. That's right. So we have a statement from somebody, a statement / question, and she says, "Thank you, Sheila, for the valuable information. Just wondering, do you have MS that makes you so knowledgeable?"
No, I do not. I do not have MS, but I make it my business to be as knowledgeable as I can. And certainly my relationship with MS Views and News has helped me along that way. And I just read. I read. And I do have, I mentioned to Stuart before we came on air, two friends that have multiple sclerosis, one gentleman and one woman. And I've talked to them extensively. So I'm just curious by nature. I started out as a teacher. And so I just want to know, why do we get this more? Why is it more prevalent? Why do we have more relapses? I mean, those are the questions that I keep asking. And I just go to the physicians like Mitzi Jo Williams, who's on MS Views and News very often, and others to get that information. I learn. I just love learning and reading.
Right. So going back to things though, going back to what you're speaking about, what are the resources that you can provide to me that we could add to our resources section on our website that can enable people of color to be able to find more resources for them? Are you able to send those to me?
Yeah, I definitely could send to you what I consider the, what do I call this? The gold standard, if you will, of how to reach out to communities of color. And there are basically 5 steps. 1, you've got to target your geography, know where you're going, be specific about the geographic area, and be realistic that you're able to even go to that area. It could be a state, it could be a city. I get down to the zip code level because that's really where you can find people in the hospitals and the clinics in the neighborhood. And by the way, I also include pharmacists in that because they are often sought to answer questions more than a doctor. So that's number 1. Number 2, then I find the community leaders, the gatekeepers, the brokers. They don't necessarily have to have multiple sclerosis, but they're just people that the community trusts. They're people that are always in the front when there's an issue or there's a controversy or there's a problem. And they can be the unlikely suspects, just people who care about their community, who care about their people. Third thing I do is I develop materials that are culturally relevant. In other words, it's not just putting a black or a brown face on a brochure. It's making sure that the language is right, making sure that you're not criticizing, you're not judging, you're not trying to make them feel bad if they don't know anything. You're trying to empower with education. The fourth is media, radio, newspapers. I shared with you, I just came back from Chicago, meeting with the 150 Hispanic publishers of newspapers. I know people always say that print is going out of style because everybody's on social media. In ethnic communities, those newspapers are held. They're usually weeklies. And it talks about not only what's happening in the community, but usually what's happening back home. So those papers are kept and they're read. And lastly, it's repeat, repeat, repeat. I want to see a poster in the bus shelter. I want to see a brochure in the bodega. I want to see a pamphlet at the beauty parlor and a barbershop. I want to plaster that zip code with as much information as possible so that at some point people are going to say, I think these people are trying to tell me something. And more importantly, in that materials, places they can go for help for their specific concerns and needs.
Right. So, being that you want to help communities with multiple sclerosis, is there a way for you to get out there and share your information with like self-help group leaders that exist around the United States?
Yeah, that's also a good way to approach it. There are health bloggers, people that are constantly in their own way connecting with other people with the same issues. They often share information. And, realistically, Stuart, these communities are overwhelmed with just life stuff, okay?
Right.
Work, kids, whatever else, taking care of elderly relatives, taking care of, non-biological relatives. So, you have to create an importance and an urgency around multiple sclerosis because it's kind of like not in the top 10, okay? Especially if they've had no personal relationship. But to me, the key there is there's help available. Whatever you're experiencing, there's help there, and empower them with information to ask the right questions, to make the community do the right thing and giving them whatever they need to live productive lives. But that point I had in my slide about looking at the world through their lens, if they don't come to your meeting, if they don't come to your event, it's not because they don't want to, they've just got stuff in life they got to take care of.
Right.
You got to figure out a way to get to them.
I know we can't have thousands attend our programs, nor do I want to pay for thousands to attend the program.
You got it. Well, the old African proverb is each one, reach one, teach one. So if I come, hopefully I'll tell 10 people about what I learned and how I can help them. So that's the only way to get to as many as possible. And social media is good. It may not always be the best way because it may not be reliable in terms of information, but it certainly is a network of conversation.
That's true. There's a person now writing, and I've seen this person attend our programs. So she writes, "Thanks for sharing your knowledge. I live in a rural area and there is no MS Society, nor is there a neurologist. How can I change this?"
Wow.
And I have to answer this first,
Please.
if you don't mind.
Not at all.
I would like you know who I'm talking to right now. I'm not going to say your name, all right? But I would like you to call the National MS Society's 800 number that they have, all right? I want you to speak to one of their navigators and tell them what it is that you're telling us right now, all right? And let that navigator tell you who you could possibly see that's in your area that probably is an MS neurologist or is a neurologist that has many MS patients that can see you as well.
Okay. Yeah, I'll add to that, Stuart, a bit of information that is necessary for all of us to know in healthcare, that DEI initiatives are now being defunded and are being shut down in medical schools. And that is very disturbing because hopefully if we had more programs like diversity programs, it would encourage young people to get involved in the biological sciences. But less than 1%, I think the last time I looked at it, of neurologists are of color. So because of the toxic rhetoric about DEI, not many are even embracing that as a career. And that's hurting all of us. And unfortunately, that was one of the solutions that was given to eliminate the disparities, more diverse workforce. And if you don't have that diverse workforce, the trust and distrust is really hard to overcome.
Well, unfortunately, the young people of this world these days, gosh, I don't know what's going to happen to this country or the world with what's going on out there, right?
Yes, indeed.
It's very difficult to figure out where their brains are at, and because they simply are not really in the game. It's right on the coattails of whatever else is going on out there, but that's political. I'm not getting into this.
Well, but you know what? Policy is often driven by the political environment, and so it's hard to avoid it. I mean, the anti-Semitism, the rise in the Asian abuse that happened during COVID, and the Native American community clearly has been, in my opinion, more abused for longer than all of those groups. But
that's correct.
And that's unfortunate. We have this dark history, but I am, the glass is half full with me, Stuart. I mean, there are a lot of Stuarts out there, and there are a lot of people who do really want to do the right thing. They're just not as loud as the others. So I think we've got to be more encouraging of each other to stay the course. I've not stopped teaching DEI, and many of the hospitals have not either. They've raised their own money to do that. But this diversity, equity, inclusion, these buzzwords now are becoming under attack. So we have to keep putting them forward.
Yeah, it seems that there was like a culture shock wave of DEI within the last 5 years, and now they're looking for something else to pick up on. Although maybe after we get past this political environment that's going on right now, maybe it will resume again. Maybe it was just on hiatus while all this other nonsense is happening.
That's exactly right. And I know we're being very careful about our language here. There was a surge of DEI after the murder of George Floyd and after the COVID pandemic was declared. And we saw globally that it was impacting all of us, regardless of race or ethnicity. So unfortunately, it takes a dramatic disturbance like that to wake people up. And it did plateau. It's now going down because of the rhetoric. And hopefully it will stay in the game if enough people like us keep talking about it. Diversity is an asset. It's a good thing. Right. It's inevitable.
We do a lot of programs on clinical trials. So it's we're always trying to keep this in the foreground, but unfortunately not enough people are attending it either, which is another reason why there's not a lot of discussion on it on the major fronts.
Yes.
So companies are not going to spend what they was trying to spend or what they were spending initially on this when they're only getting a handful of people attending.
Yeah.
Right?
But I think the other problem is it does take longer. It does cost more. Two things that researchers don't want to hear. That's
true, but it's true. But if the different communities of people of color or ethnicity do not push their communities to get more involved, then who's really at fault for it not taking place?
You're absolutely right. There's a website that's called Drug Snapshots, and it lists the number of drugs that have been approved, and it also lists how many people of color in the clinical trials. I could tell you there are a lot of zeros on that list.
Right.
Okay.
Right.
But again, I try to take race out of it. This is about good science. This is about genetics. It's not about what you or I look like, the color of our skin. Race is not really scientific. It's really about ethnicity and genetics. So we still have to keep hitting that and keep educating people and keep talking to people about you play a role in the quality of your care. If you don't participate in the trials, then you've played a role in poor quality. So I mean, it's a personal responsibility. And clearly when those who have been involved in trials, they get the best care, the most personalized care, the most direct care with their providers. And if we have more of them become ambassadors and talk about it, which is what I've done in most of the trials I've done, it makes a difference. I want to see somebody who looks like me that's been through this.
So that takes me to another thought that I just had about, we were trying to promote a clinical trial one time, and somebody came over to me and says, "Why do you do this all the time? Don't you know that Black people just simply don't want to get involved with clinical trials?" I said, he was a young person. And I said, "Why is this?" I said, "I know the answer that older people will say, but I want to know your answer." He says, "Well, because that's Tuskegee." I said, "Tuskegee?" I said, "It's called Tuskegee."
Right.
And he said, "Yeah, but that's what I heard is that, they did something wrong to us." I said, "That's what you heard. How much do you really know about it?" "Oh, I don't know anything. I was only told that I should stay away from this."
Wow.
So again, where are the community leaders, the younger community leaders that are pushing to get people to know that, unfortunately that did happen, but it's not going to happen again, not with all the eyes on everything that's going on out there. So how do you get people to be better educated? Where do you find your leaders to say, we've got to get back in this game again? Because another thing is these drugs are being approved because clinical trials are basically with white people. How will you ever know if an Asian or a African American or a Black American or a or a Native American Indian or anybody is going to be affected by it if they do not get into the clinical trials.
So true, Stuart. I mean, in your example of talking to that young person is what I hear all the time. In fact, I hear that the government gave those men syphilis, not that they denied them care. So there's a lot of misinformation out there. In fact, I'm talking to one very prominent Black fraternity, trying to get them to be some of the leaders who can begin to talk about clinical trials, and they have some of the same misinformation. I don't want to be a guinea pig, so
Right.
and nobody does, it's not just Black people,
Right.
nobody wants to be a guinea pig. However, when you talk about how the lack of quality in terms of the care will be if you don't have clinical trials, it gets to them: dosing, side effects, you just have to keep talking. Even the leadership needs to be spoken to about it. And COVID made it a little easier, because people saw thousands were dying every day. And when the vaccines were discovered, many lives were saved. So kind of people changed their opinion about it because they saw it. I talked to an elder in the Native community. He lived during the polio era, and he said he saw the children who were crippled, and when he had the vaccine, it saved lives. So you've got to give them that historical perspective so that they have the facts. But right. It's not going to be an easy conversation. And to your point, Stuart, when I talk to young people, they may not know Tuskegee, but they refer to the mistreatment they have of the healthcare system as young people. They think I'm a drug dealer. They think I'm this. They think I'm promiscuous. They think I'm not eating right. So it's not only historical egregious medical abuse, but contemporary discrimination on the part of the system.
So that goes back, though, to the system. So the healthcare industry wants more Black Americans, Asian Americans, and others to be involved with the clinical trials. Then why aren't they hitting the streets, so to speak, about getting into the communities rather than relying on patient advocacy organizations to be doing these programs? But if they want to invest more in it, then they should be boots on the ground and getting in there and meeting with support group leaders, whether they be in Seattle, Washington, or Washington, D.C., or the middle of Atlanta.
They're not comfortable in that space. They talk a good talk about multiculturalism, but they're not comfortable because they don't want to do the wrong thing. So they don't want to go into these communities. People of color are often put into the situation where you're the only one of color. Aren't many white people who've only been in non-white communities. I mean, it's not something they don't know, and they fear the unknown. They know what they know based on movies and TV and the media, but they don't really know what it's like to be a person of color, and they're afraid that they're going to do something wrong, be called a racist, or behave badly. And that's unfortunate. And the pharma companies have no time. They think they want to do this right, but they find out that it is labor intensive. You've got to show up. You've got to be in community and not be afraid, and just meet people where they're at. Whenever I go into a community, Stuart, that I'm not familiar with, I give a disclaimer. I often tell the people, look, I'm curious about your culture. I want to learn more. I'm probably going to say something wrong and make a mistake. I apologize because I want to learn. And when I give that disclaimer, people get comfortable. I don't come in like I know it all and I'm going to save the day and they don't know anything and they're ignorant. No, I come in learning, wanting to learn and share. That's what makes our country beautiful. That's our greatest asset. And unfortunately, we don't always treat it that way. So again, I was raised in a family that was open. It didn't matter what color you were, blue, black, green, or purple. It's if you had respect, you had integrity, you were a good person. That's all that mattered. And my parents were raised during the Depression in the Deep South. So they certainly had a lot to be negative about, but they weren't. So I was blessed in that regard and fortunate, and I've carried that into my work.
Okay, great. Thank you very much for that. So we don't have any other questions. I don't want to keep you on all night. I would love to have this conversation with you on a bigger platform, right? And we could go forward and do that another time, but we need to bring in community leaders into this. And that's something that I'll discuss from my end, and we'll see what we could do going into 2025 by bringing in a host of you, me, and a bunch of community leaders of different backgrounds, and we'll really have a good rap session, all right?
You're so right. And I use the expression, E pluribus unum, out of many one. So we have to know that we are one. And my goal in my career, Stuart, with privilege of meeting folks like you, is I want to comfort the afflicted, but afflict the comfortable.
Thank you very much. And for those that are remarking that they enjoyed this program, thank you so very much for being here and spending the time with us. And please share this information that you heard tonight, okay? And tell people that they need to get on the bandwagon here. They need to start paying attention to what the needs are out there instead of hiding under a rock waiting for somebody else to do it.
Exactly right. Well, my privilege, as always, Stuart, to work with you and your team. I applaud what you're doing. I'm honored to be a part of the conversation.
Happy 2024, and let's look into 2025. Everybody have a great night, and we'll see you online soon, okay?
Bye-bye.
Take care.
Bye-bye.